Okay, so we are doing comprehensive transthoracic echocardiography exam, and we also want to understand how to obtain standard views. The objective of this lecture is basically to show what you need to do, where to place the probe, what views are given, when do you apply pulsed wave, continuous wave, how does it look? We won't explain in details because we have individual lectures concerning such. But today I just want to show how you can acquaint yourself with the images of echo, whether in color, pulsed wave, and just to understand some echo images and how they look. That's why I'm so much concerned with the anatomy, so that as I point at things, people must be aware and get to know what is going on. So I'm trying to press. It's not moving, it's paused.
Kaya muy bien, huko.
Sorry. Okay. You can see it still.
Yeah, it has moved. It is on compressive thoracic echocardiography exam, right?
Me, I'm saying it on, it's on the same.
It has moved. It's on the first page.
The first page of objectives.
First page, the front page.
The title.
Okay, is it on objectives now?
No.
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 Eish. Eish. Can you see something?
No progress, sir.
Anything? Okay, it's moving on my side. Is it moving there?
Yes.
Yes, yes, yes.
Okay, we are on objectives, not so.
Yes, we are.
Yes, yeah.
Okay, thank you, thank you, thank you. So my objectives are to explain the patient position. Don't worry about patient positioning. I know you've done a lot of patient positioning. We also need to, again, learn patient positioning, cardiac ultrasound. Sonograph positioning, where you're supposed to stand and why you're supposed to stand there. Handling of the transducer, machine setup, standard transthoracic windows, identifying echo structures, M-mode examination, 2D examinations, and Doppler applications. So I'll be quick on some of the points so that we get to move fast. So this is the patient positioning. So for a cardiac patient positioning or echo, patient is typically examined in the left lateral decubitus. You let the patient sit in supine, and then the patient is in left lateral decubitus. The reason is very simple. You want the cardiac or the heart to become more closer to the chest cavity. Okay, you want the heart to come more closer to the chest cavity on the anterior chest. And then raise the left arm above the head to spread the intercostal spaces. Remember, the cardiac probe has got a very small footprint, very, very small footprint. The reason is that we want that footprint to go through the intercostal spaces. Yes, sometimes a patient may not be in this typical position. Maybe they're very sick, or they cannot manage, or due to other conditions, you still have to find a way and do that. However, by design, the cardiac probe has got normally that small footprint. So even if sometimes patient is unable to cooperate, you can still go through it. And we also explained that we use a low frequency which has got high penetration. Remember, the heart is seated deep in the chest cavity. So we spread the ribs so that we can see the intercostal spaces down there. How do you handle the transducer? One of the thing that you need to do is the same probe that you hold. It's the same probe that we normally have, but make sure you hold it like you are throwing a dart. For those of you who have played a dart before, but you hold it like you are throwing a dart. It's the same probe, except that the images in the echo there inverted, which I will explain. Make sure you stabilize the transducer against the chest cavity, the chest wall, using the little finger. There is a way you hold this, and that should not be a problem for somebody who has been doing ultrasound. Then always ensure that the position of the transducer is oriented to the cardiac views, which I will explain when you're doing this echo. So when you're handling the transducer, you have your index there. This is the pointer of the index. Okay. The reason why I'm showing this position, it's because this is the first position that you pick the views. So you let your patient remain in that position, and then orient your heart. Once you put the patient in left lateral decubitus, the heart is in the long section, in the longitudinal plane. The apex becomes more closer, just around the nipple, around third to fourth intercostal spaces or ribs. You find that the apex will be somewhere there, but make sure the pointer or the index is pointing to the right shoulder. That's when you can pick some images that can be of meaning. So make sure that the pointer is well oriented, and then identify or orient yourself to the expected cardiac structures that are given. I will show more on this one. Sonographer always must be, not always, but make sure that you examine the patient on the right side of the patient. Then you can also be on the other side, though it's more strenuous for those who are left-handed to start examining the patient on the other side. But typically, the operator can be on either sides as long as they are able to pick images that are of good quality and they are oriented according to the image expected. Get comfortable, adjust your bed so that you don't strain your shoulder. The more you do echo, in my experience, you find that sometimes you find the very bulky patients and you have to strain. So you start having some kind of strenuous pain around your waist because you are trying to pick images. Sometimes females with the big breasts, it's also a challenge. You have to go down the breast until you examine, you pick the heart. So it can be a little bit straining when you're examining that. The examination table must be adjusted so that it's appropriate and your elbow allows you to rest comfortably, slightly on the bed, not necessarily leaning on the patient, but it's very important that your elbow is comfortable so that as you pick your structures, you are able to pick things accordingly. Position the patient so that the examination can be performed without leaning on the patient. With the advent of COVID also, you always avoid unnecessary contact with the patient. And then I prefer to examine my patients, not only with echo, but I think I've adapted. Always get your glove. If you have the gloves, get your glove just on one side and then do your technique like that. We'll explain. So the standard transducer positioning. So typically we've got 4 to 5 positions where you can put your transducer. Hello, is the class there?
Yes, we are. We are there.
Yes, we are here.
Okay, so there are 4 to 5 positions where you can put your transducer. The first and most important view or transducer where you put is the left parasternal window. Left parasternal window. Why is it parasternal? It's just adjacent to the sternum. You see, so it's just the sternum is here. The sternum is here. So you put your probe just next or adjacent to the sternum. You are going to have your longitudinal section or parasternal long axis of the heart. We'll show you how that one will look at. From there, from this view, you can do quite a number of things. And for me, I always emphasize to get the best image of this view, because this is one of the most important view where you can pick your ejection fraction, you can do your IVS thickness, you can quantify the aortic root, you can do the papillary muscles. You see a lot of things in this view. It's very important view, and I always emphasize people to make sure that they get the best image of this one. The next view you pick, it's the apical 4-chamber, apical 4-chamber, apical 4C. Now, where do you exactly put this? It's just below the nipple, around 3rd to 4th intercostal spaces, ensuring that your probe transducer orientation is in order. This is also a very important window. Why? It gives you the whole 4 chambers, the 2 ventricles, the 2 arteries, the mitral valve, the tricuspid valve. You see them very nice. You can also modify this and twist and get your 5-chamber. Don't be surprised when you find that people are talking about the 5-chamber. It's through this 4-chamber view. That's where you can pick the 5-chamber view. Apical. This is when you can also quantify issues of diastolic function. It's the apical 4-chamber. I'll still demonstrate how this comes about. So apical 4-chamber, very important. Where do you put your transducer? Just below the nipple. Just below the nipple. Where does the transducer marker points? It points to the left. If you are using the cardiac probe, it points to the left. If you are using a curvilinear probe, a non-cardiac probe, like most of you, maybe you may not have the cardiac probe. So you find that I've used a curvilinear probe, which is not a cardiac probe. So you turn your probe. You turn your probe. You let the pointer of that probe to point on the other side. That's when you can pick the best or the acceptable oriented structures. And then the third view that you get the subcostal view. The subcostal view, you go through the xiphoid. You go through there. This also gives you the 4 chambers, but it's a very important view for pericardial effusion. Very, very good for pericardial effusion, which doesn't mean you cannot see pericardial effusion on these other views. You can, but this is one of the best. When we come to do congenital anomalies, I'll also come and show you why the subcostal view is very important, because it helps you to understand certain dropout artifacts. This is called the subcostal. The right parasternal view, normally it's not an important view, and in routine cases, it's very, very, very rare that we use this one. But if you want to see the right ventricular outflow tract, this is also good. But in most cases, this is not very, very, very useful during echo cases. And then we've got the fifth transducer position, the suprasternal, just at the sternum here, the sternal notch. This is one of the very important view again that you can use when you want to understand the aortic arc. Very, very important. Those questions I was asking you about the branches of the aortic arc, this is where you can appreciate them. Where does the marker points? The marker points towards the head. Then the patient extends. Let the patient remain in supine, and then the patient extends the neck so that you pick it. I have an image, so I'll still demonstrate. Also with the subcostal, I forgot, you let the patient remain in supine. You let the patient remain in supine, and then let the patient flex the knee so that you relax the abdominal wall muscles. When the patient is just straight like this, the abdominal muscles, they have contracted. So it's a little bit hard. So let the patient flex the knees so that you relax the abdominal muscles, and then you push in your transducer. Don't compress too much, but make sure you do it just gently to get that one. So basically, these are the five standard transducer positioning, and these needs practical so that you are shown. If you are good at seeing and do what you can demonstrate them, you put them like this, you put them like this, you send them on the group, we see, and then we criticize it. And I should mention here that if you are using a curvilinear with a big footprint to analyze the suprasternal, you are going to have very difficult challenges because the footprint is too big. So you won't pick it. It won't go into the sternum there. You won't. You have challenges. So this is also good for issues of coarctation, aortic aneurysm, and basically if you want to see other anomalies around here, this is very important. And then when you look at the orientation of the heart also, it's very important for now as cardiac sonographers, you start now orienting and having a schematic diagram in your head so that you don't just think that things are happening. No, you are in charge, you are controlling, you need to understand the anatomy behind what you're doing. Very, very important. So I've already explained, typically transthoracic windows. The reason why I'm emphasizing transthoracic, because we also have the TEE. Remember, transesophageal echo. So this is what we are learning is the TEE. So we have the left parasternal long axis, which is abbreviated as that, and short parasternal axis, apical 4-chamber and apical 2-chamber, subcostal view, suprasternal view, and right parasternal long axis. I've already explained those. So I'll go straight to the transducer and patient positioning for plaques, which is parasternal long axis. So like I explained, third to fourth intercostal space, you put your transducer with the patient in left lateral decubitors. What are the structures that are imaged or visualized? Anatomically, you are going to appreciate the left atrium. I don't need to explain what LA is because we gave the abbreviations. We are going to understand and appreciate the aortic root, the left ventricular outflow tract, the left ventricle, the right ventricle, sorry, the IVS, which is the septum, the left ventricular posterior wall, the descending aorta, the mitral valve, and the papillary muscles. These are going to be appreciated in the parasternal long axis. You are going to see them and appreciate them in that view. How do they look? This is how they look. So in long parasternal view, I think if you remember, I was asking about what is diastole, what is systole. Those terminologies, they are now coming. They are now coming in. When I said diastole, you must understand what is happening with the heart. It should not be Greek. So for the sake of explanation, diastole, it simply means the heart muscles, they are relaxed. The heart muscles, they are relaxed. And when the heart muscles are relaxed, what does it mean? How do we know it? When do we say these heart muscles have relaxed? It's a question of understanding now that these muscles have relaxed, and what is exactly happening within each and every part of the heart. I asked, I think, was it Twambo or Judith to say, the four diastolic phases, they are very, very important, which is isovolumetric, the rapid filling, the slow filling, and the atrial kick. There are four: isovolumetric, the rapid filling, which we call the E, the slow filling, and the atrial kick. Now, when you look at these mitral valves, the common sense tells us that, or the background information, we know that when the heart muscles are relaxed or it's in diastole, there is filling of chambers. Now, which chambers fills? The left atrium fills and pours blood into the left ventricle. So the mitral valves are open. And when the mitral valves are open, it simply means the left ventricle is filling. And if the mitral valves are open, it simply means the aortic valves will be closed. Why is the aortic valve closed? Because the pressure, remember the pressure between the left ventricle and the aortic valve in the systemic circulation, there is pressure difference. There is no pressure difference yet. This aortic valve will only open when the mitral valve closes. So this is why I'm emphasizing the point of diastole. So these mitral valves, they are open in diastole, blood will come in. And then you have that, don't worry about that. But the features that you see, one is that this is the septum in long section, longitudinal section. I'll explain, there's a diagram I'm going to explain. This is the septum. And then this is the aorta in long section, aortic root. This is where the aorta starts. And then this bulging sign, this bulge, you can see that there's a bit of bulging here. Here, there's a bulge, and then there's also this. So in long section, these are coronary. It's a coronary artery. The right coronary artery, the left coronary artery, and we don't see the non-coronary artery. So these coronary arteries, very important to understand them at this level. I'll show you in another section. So this is what is happening here. This is the anterior mitral valve leaflet. And then we've got the posterior mitral valve leaflet. It's not clear here, but I'll show you. But these two, they close here. And then this part here, from this part up to here, this is the LVOT, left ventricular outflow tract. This is the tract. I'll explain what that is. So you are going to see the right ventricle, the left ventricle, the mitral valve, the aortic root, the left atrium. This is the left atrium, and then the descending aorta. I'll still show you where it is. Okay. This is now in systole. I just want you to appreciate that, oh, this is what systole now. Now, the systole part, you find that the mitral valve is closed. The aortic valve is open. Still, we are going to see the right ventricle, the left ventricle, the left atrium. And this structure that you are seeing here, start getting used to it. This is the descending aorta in cross section. I'll explain what this is when we start going into it. I'll explain. And remember, in systole, when the myocardium is in systole, the myocardial muscles, they thicken. They thicken. Get this point? This is a physiological explanation. They thicken. And during relaxation or diastole, the heart muscles, they thin. That's why don't make a mistake to quantify LVH or you measure the septum when the heart is in systole. Those are wrong measurements. Okay, parasternal long axis. I'll still show you the parasternal long axis, but using the M mode. Don't get confused. This is the same 2D. Remember, we had our 2D. This is a 2D. Nothing color, nothing else. I've just applied the M mode. The M mode. Now, this M mode, if you look at where this scan line is passing, have your mind that you have, this is a long parasternal axis. I put my M mode nicely across the aortic root, sorry, across the right ventricle there, from there up to here, and then from here up to here, this is the aortic root, and from here up to there, this is the left atrium. And this is being depicted down here. So this part from here up to here, from here up to here, it's a distance from here up to here. That is the structure down there. And then from here up to here, it's a distance from here up to here. This whole thing that you are seeing here, this is the aortic root. But from here to here, this is a distance from there to there. Don't miss it here. And then from here up to here, it's a distance from here up to there. Any questions on this one before I move? Any quick question?
I haven't understood. Please repeat. Sorry.
Okay, no problem. I'll repeat. This is our 2D. This is our 2D image. We haven't applied our M mode. So this is our 2D again. Let's assume there is no this, but I'm now applying the M mode. Remember the M mode, like I explained last time, it gives you sorry, time against the y-axis, gives you velocity and the movement and everything. This time gives you the time interval. The x-axis gives you the time interval. And then I mentioned, I remember during protocols, we use M mode for measurements. So the depiction of what is happening here, it's what is down here. But how do we interpret it? This is the right ventricle. Don't worry, in long parasternal axis, you get used. This is the right ventricle, okay? And then this is the aortic root. This is the left atrium. And if this is the left atrium, here, this is the mitral valves. This is the left ventricle. And then this is the left ventricle outflow tract. Blood is going up there in longitudinal, parasternal long axis. So what you are seeing here now is that we've depicted whatever is there into this. So the distance from here, this point up to here, it's a distance from here, I'm pointing now, up to there. So this whole area here, this part, it's the right ventricle, because this is the right ventricle here. Are we together there?
Yes, I've understood that.
Okay, from here now, I've moved from that structure. From here, this point up to here, it's this point from here up to there, or the one I've measured from here up to here. What structure is that? Your job is to know the structure. It's the aortic root. So it's the distance from there to there. We move. Are we clear there?
Yes.
And then what structure is this? According to long parasternal long axis, this is, for now, let's cram. but it will make sense, I know. And then this one from this whole thing here, you see, the left atrium, and then this scan line is passing from there up to here. And this is the structure that so the whole lot of this thing here, down here, it's a left atrium. Why are we having it so long? Because this is a cardiac cycle. It's repeating. It's repeating. And when you look at this aorta, this whole aorta, from here to there, this whole thing, it's a aorta. So it's going like this, more like it's making a wave. It's making a wave. It's making a wave. It's making a wave. So it's contracting, relaxing. Remember, it's pulsating, contracting, relaxing, contracting, relaxing, contracting, relaxing, contracting, relaxing. And then when you see this line, this line, this line, that line, this line, it's a closure line. So during this cycle, this phase here, excuse me, the aorta is closed. It gives you a line, one single line. When it reaches here, it's open. Okay, closed, open, closed, open. So where you see a line, it's closed. And the aorta is only closed when it's the cardiac muscle is in diastole. When it opens, okay, when it opens in AD diastole, in systole, it opens. So this is the opening here. This part is the opening part. Sometimes you find a very nice box. It forms a very nice box. I'll explain where that box comes from. For now, this is a depiction of the M mode on the long parasternal axis. Are we clear?
Yes, we are.
Okay, and then the other thing is when you look at this bright structure here, that bright structure there, that is the pericardium. We know in sonography that the echogenicity of a structure is determined by the density. So the pericardium it's a vascular fibrous tissue. It's very dense. So it appears white. And this is what we are picking now down here. This is the pericardium. Whenever there is pericardial effusion, remember I said M mode is very sensitive. So it can pick pericardial effusion even in the long parasternal axis. The rest we'll explain as we move on. I explained what this is. I'm just trying to emphasize the point of M mode on long parasternal axis. You can see now I've just shifted, or they have just shifted the scan line from the aortic root, to now where? Your job is to know which anatomy am I cutting. That is your job. Your job is to know which anatomy am I cutting. So in this case now, we are cutting the long parasternal axis at a different level, at a very different level. Now, which level are we? We are at the ventricle. Still, we have a bit of the right ventricle there. And then this one, this is the septum, the IVS. From there, coming down up to here. This is the left ventricle. Okay? And it goes on down there. So this is the depiction of that. Where is the right ventricle? In fact, they have even labeled here now, right ventricle. Okay? Now, look at this. This O line, it's up, down. It's up, down. It's up, down. So this is in systole, diastole. Sorry, this is in diastole when it's like this. This is in diastole. When it goes down, it's in systole. Okay? It goes up in diastole. So it's caving and it's in synchrony. Excuse me. It's in synchrony with the left ventricular posterior wall. It's in synchrony. When the left ventricular, when the septum is in systole, also the posterior wall, because this is the same wall, it's also in systole. When it's in diastole, it goes in diastole. So when you look at these figures, these abbreviations they have put, this is left ventricular internal diameter in diastole. Left ventricular internal diameter in diastole. This is what I'm explaining. The heart muscles there relaxed. Now, this is left ventricular internal diameter in systole. Are we together? Hello? Are we together there?
Yes, we are.
Yes,
Yes,
it's
we are.
in systole. So when you find these figures or these abbreviations, please, they should not scare you. Know what this S is standing for, know what this D is standing for, and know the parameters and where you are measuring. We move. We are now still on M mode, but where are we pushing? We are putting now M mode on the mitral valve level, still with the parasternal long axis.
I have a question, Mr. Mulenga. Sorry for the interruption.
Please go ahead, no problem.
Okay. Yeah, so like the time you on the LV D,
Yes.
left ventricular.
Okay, I can go back. I can go back.
Yes. Why are we measuring the internal distance at each level in diastole as well as in systole? Why are we doing this?
Okay.
Do we have to do this whether we're doing a normal cardiac? Is it a routine, or why are we doing it?
Okay, I think the objective of this lecture is to first orient you to images.
Okay.
But just to clear you, because I cannot start telling you everything here. That would be it will be too much. We will overload each other.
Okay.
Yeah, but for the sake of explanation, the reason why we are measuring here from there to there, okay? A patient comes with just an echo. We do this one because ejection fraction is calculated by the difference between the left ventricle inner diameter in systole and the left ventricle internal diameter in diastole. That difference, okay, calculates automatically the ejection fraction.
All right.
That's why if you see here, there is a septum, there is an internal diameter, there are all those things, and here it's giving them ejection fraction. I will show you even how to do manually so that you understand manually, and also how to do it with them, because the machine does all these calculations. The secret is do the correct technique.
Okay.
Yes,
all
so
right.
Don't worry. I'll explain all those details. For now, orient yourself to what is going on.
Okay.
This is the M mode again at mitral valve level. Again, this is the LVOT, the left ventricular outflow tract. Okay, still the distance from there to there, this is the septum. Again, it's passing there. It's a depiction of this. Again, step by step, they have shown you this is the septum. Again, this is the septum. This is the right ventricle. That is the right ventricle. This is the left ventricle. This is the left ventricle. This is the anterior mitral valve leaflet. And this is the anterior mitral valve leaflet. This one here. And this is the posterior mitral valve leaflet. This bright thing, it's a pericardium. Please, it's a pericardium. And then you've seen this, there is a dark part here. Just continue seeing the parasternal long axis views. It's a consistent structure. This is a descending aorta. Very, very important. Don't miss that structure. That is the descending aorta. And you need to understand it from that view. So what I don't want from this class is to be pointing at things carelessly. That one I'm not going to allow. Know things and know why they are appearing the way they appear. This is the mitral valve, posterior mitral valve leaflet, anterior mitral valve leaflet, left ventricle outflow tract, the aorta, the septum, the RVOT. And then we have the pericardium, this fibrous tissue here. And then we've got the descending aorta in cross section. We move. Okay. Okay. Just some few things that you need to understand. These things will still be repeating them, but I just want you to be comfortable with certain things. So when you put your M mode on the mitral valve leaflet, you are going to have something like this. So in diastole, when the heart muscles have relaxed, the anterior, get used to this abbreviation, the anterior mitral leaflet. Anterior mitral leaflet movement exhibits an M-shaped pattern. Now, where is it? This is it. So this one, this is the M. From there, that is the M. That is the M. This is the typical normal anterior mitral valve leaflet. When you put your M mode, this should not scare you. What is the E? What is the E and what is the A? Remember, I think I asked, was it Twambo? I asked, what are the phases of the diastolic phase? Okay, the catch is here. Please don't get confused. The catch is here. They are saying in diastole, not in systole. So in diastole, there are certain things that you need to have in mind. One, the heart muscles have relaxed. What is happening within the heart? The left atrium is feeling. The left ventricle is feeling. What is happening and where are things happening? So this E is the early phase. I'll explain. I'll come and explain these things it's unfortunate we won't do the physiology together because you need to do that part. If not, we have to do it as a discussion. So this is E is the early phase. Okay, this is the feeling. Okay, A is the atrial kick. Atrial kick. There are 4 phases, like I mentioned, of the diastolic phase: isovolumetric, rapid feeling, and then the slow feeling and the atrial kick. We don't see all of them on echo. The PML, the posterior mitral valve, posterior mitral leaflet, posterior mitral leaflet. This is the one. So it's also coming like, this is a typical, this is how it comes in diastole and then it closes. So they have given you these abbreviations. D, left leaflet opening. The leaflet is opening just here. The E, the peak opening, rapid feeling. The F, the partial leaflet closure. It comes down. Again, it will go up, the peak opening, the atrial contraction. I'll come and explain this. Don't worry, please. The C, this is the leaflet closure. So once they come together here, they close. Again, remember, this is M mode. The cycle continues. Again, you're going to have another M. Just like that, and it continues. Your job as you do your echoes is to understand the patterns of this. You can see mitral valve stenosis from here. You can see posterior mitral valve prolapse here. You can see a lot of things here. And for your own information, these echo images, sometimes they don't even make sense when a layperson looks, not until your eye is trained. That's why I'm not going to let people just comment on things and know what you are pointing at. Otherwise, I'm going to say, no, I don't know Twambo, I don't know Judith, Mr. Mwawa, I don't know him with the echo, because I never mentioned this. So I need people to be acquainted with that. These are just different cardiac phases, which I won't explain because I wanted just to show what is happening here. This is in end diastole, okay? And then this is in systole. But I want you to notice that in systole, like I mentioned, the myocardium contracts because systolic simply means cardiac contraction. So it thickens here. It's thick here compared to when it's in diastole. It's very thick. So when you want to quantify the thickness of the myocardium, the IVS, the septum, don't do it in systole. That's a disaster. And that figure, by the way, echo deals with very small figures. So any wrong technique, any wrong measurement, it simply means you are giving wrong diagnosis. We'll explain that. Okay, I talked about it. You find that it will give you this box thing that we are talking about. So remember, I said this is in diastole. This is in diastole. This whole thing here, this tubular-like thing here, it's the aortic root. It's in diastole, systole, diastole, systole. The cycle continues. Why are we having this line here? Excuse me. The reason why we have this line, it's because the heart muscle is in diastole. It's feeling, the left ventricle is feeling. Remember, when the left ventricle is feeling, the mitral valve is open. And when the mitral valve is open, the aortic valve cannot also be open. It's closed. That's why we are having this line. The moment it goes into systole, the aortic valve will open. That's why they have put systole here. It will open. Very important to understand that part. Again, I'm just trying to demonstrate this is the aim we are talking about. This is the closure, opening. Okay. I talked about the EPSS. The EPSS. Mr. Mwamba, I'm seeing you are here, sir. What is EPSS? You missed the quiz questions. What is EPSS? I can see you are there. Mr. Mwamba. Just abbreviation. We just want abbreviation. What is EPSS? I want to make a point here. Okay, Judith, are you there? But Mr. Mwamba, are you there?
I'm here, yes, but I joined the class late. I thought I had taken it for granted that it was at 19 hours.
Okay, it's okay, but we are interested in the EPSS. No one discussed the EPSS in this class. What is the EPSS? We gave it as an abbreviation last time. Okay, the EPSS is end point to septal separation. I want to make a point here. So EPSS, it's when the leaflet, this leaflet, the end, the E, remember E, Eliphaz. The end, if the separation between the septum and the E wave is very important. How far it goes from here to there. It's very, very important. End point to septal separation. End point to septal separation. This is the distance from here to there. How much separation? We measure this figure here. If it's between 7 to 8 millimeters, then the ejection fraction is 50%, more than 50%. We'll discuss this. But this is why I wanted to emphasize, this is where the EPSS comes in. So all those abbreviations I gave, they are not just there, no, they will come into play. So we move on. So just to understand the planes, whatever I've been discussing here and whatever, have this diagram in your head. So we've got this heart, and when you see this plane, the plus parasternal long axis, you are cutting your heart in the long section when the patient is in long parasternal, left lateral decubitus, When the patient is in this position, you are having that kind of longitudinal section, and that must be understood. And how you understand that point is to ensure that the part which is closer, to the chest cavity must also be understood. Sorry, class, just a minute. My laptop is about to go off. Just a minute. Oh. Okay. Okay, I can now continue. Okay, I'm back. So when you look at this, this is the long parasternal. You are cutting your heart in the long section when you put your probe here. Remember the apex, when you put your patient in a left lateral decubitus,
we justified to say the heart becomes closer to the chest wall. So this part becomes closer. So when you put your pointer, your probe here, you are cutting your heart in a long section. And when you turn your probe, it's unfortunate practical, I can't show you, but when you turn, just maintain this. When you come into the parasternal long axis, which is the parasternal short axis, sorry, you are going to cut the heart in short section at the parasternal short axis aortic level. You are on top now. Imagine that you are seeing the heart from the top at a certain oblique angle. So you are going to pick the short parasternal axis at aortic level, and I'll show you a very nice technique. From there, don't even move too much. Just on this position, start tilting your probe downwards. You are going to get your mitral, your parasternal short axis at mitral valve level. Again, tilt further. You are going to pick your parasternal short axis in apical at apical level. This I need to show you, but this is what should be in your head. But the key point here is that maintain your probe here. Once you pick, just get your short parasternal axis. Get your long parasternal axis first, and then turn your probe. There you need to be shown. You just turn it just anti-clockwise. Then images will come out. Don't mambo jumbo from here. Maintain this position and tilt your probe downwards. Images will be coming out. This is a practical thing that I need to demonstrate. What is the related anatomical structures at short parasternal axis aortic level? This is what should be in your mind. Imagine you are looking at the heart from the top, okay? And this is the top part. And then imagine down, you've got just down there, you've got the mitral valve. And then you go down there, you've got the apex and everything. So on top there, you're going to have this whole structure you are seeing here, okay? It's the aortic root. Now, the aortic root has got 3 cups, the right and the left cups and the non-coronary. Okay, it forms a bend sign. I think as you read, you'll be finding the bend sign. This is a common bend sign in echo. We'll be seeing it. So only 2 coronary arteries feeds the heart. The other one is a non-coronary artery. Now, at that level, adjacent to the non-coronary, you've got the left atrium. After the left atrium, you go through the right ventricular outflow tract. Don't worry about these images. They will start making sense as we continue. From there, from the RVOT, left ventricular outflow tract, you've got the pulmonic valve. Blood now is going to the lungs, the pulmonic valve here. As you go immediately after the pulmonic valve, you are going to have the main pulmonary artery or the pulmonary artery, which branches into 2, the right pulmonary artery and the left pulmonary artery. So in terms of pulmonary stenosis, I'll come and show you. We'll see how these things comes. Your job is to understand what are the related structures. Don't cram, but understand the orientation of the probe and how you are picking that. In echo, this is how they will appear. Okay. The pulmonic valve, the RVOT, the tricuspid valve, the RA. This view is very important, the RA and the LA. When you have a defect or a septum, the ASD, you can also use it, confirm it in this view. We'll explain it further. Now, remember, I said when from aortic level, short parasternal axis, you can tilt your probe slightly down. This is what you are going to have. You are going to have the mitral valve. The mitral valve, okay, the mitral valve level. This is the mitral valve here. This one, this is the mitral valve. It gives you the fish mouth. When you hear of a fish mouth, this is the fish mouth. Here you can do your area and quantify and do everything. How narrow is this? How is the stenosis? You can quantify stenosis. You can do the area here. There is a normal area of the mitral valve area. And then surrounding the mitral valve, it's the left ventricle. We know this is the left ventricle, this one. And then this is the septum. Okay, this is the septum which goes, this bright thing, this is the pericardium. Then the right ventricle. Now, this view is very, very important in cases of myocardial infarction. Okay, we are not discussing myocardial infarction, but I'll come and explain the motions here. I'll come and explain the motion. Very, very important. Make sure you get the best image. Very good in myocardial infarction to understand. Again, you move down. If you don't understand what a papillary muscle is, that is another problem. That's why I'm busy emphasizing and give what is a papillary muscle. If you tell me pass, you are passing the lecture. So this is short parasternal access. Again, you tilt your probe. I'll keep emphasizing, this is still a practical thing which I need to show you. Just tilt your probe, you go to papillary muscle level, still in short parasternal access. So these are the papillary muscles. Anterior papillary muscles, posterior papillary muscles. They just look like that. Remember, papillary muscles attaches the cordial tendini to the mitral valve leaflets. Okay? And then you've got this, excuse me, you've got this right ventricle again. You've got the septum and the alveoli. Okay? Short parasternal access, papillary muscle level. You go down again. Just tilt your probe. This is the last part that you pick. Short parasternal access, apical level. This is now at the apex of the heart, down there at the apex. Okay, here, let me do this. Here, at the apex here. So what I've been explaining, I was here. I tilt my probe, I come here. I tilt my probe, I come here up to this level. And if you look at the diameter, I was here. Okay, this was my area of interest. I was here, aortic level. I move, I come here, mitral valve level. And then the diameter of the left ventricle is quite big here at mitral valve level. I go, I move, the diameter is there. Papillary muscles. I move until I go down there. Any questions before I proceed on this one? Any question? Hello? Hello, feedback.
Following attentively.
Okay, thank you. I proceed. Okay, this is just labeling. You don't need to go through it. You can read it in your own time. Okay. The next view is a patient position for apical four chamber. Remember, for those of you who started the lecture, I said the apical four chamber is also very important for a number of things. Now, orientation, very important. If you are using a cardiac probe, when you look at this probe, make sure that the probe marker I mentioned earlier, it should point to the left side of the patient. And on the screen, look at where the pointer is. Dot on the right side of the screen. This is very simple to understand. Put your probe there. This is the nipple just below it. And one thing that you are going to notice that this will be labeled as the left ventricle. This will be labeled as the right ventricle, right atrium, left atrium. Now, this footprint of this probe is here. So this is more apical. This is more apical because the apex is here, probe orientation. And if the apex is here, this could be the top part of the heart. It's inverted. So don't get confused with echo images. It's inverted. Because of this, this is where the footprint is. This is where we are. Left, right. If this is the right ventricle, this is the right atrium, left atrium. This is the septum, this septum, IVS. Then from there to there, we've got the atrioseptum, and then the rest continues. We move. Again, this is how it will look.
Just a question on the previous slide.
Okay. Please.
So this patient is in what position? Is it true supine or?
Thank you for that question. I actually meant to explain that. Thank you for being attentive. This patient, it was a lazy echo. We call it lazy echo. If you see the hand is not even raised. The patient is just, and you see a lot of people doing echoes like this, and they justify why they do this. There's nothing, but if you want to optimize images, please do the correct thing. So this patient was in supine, if you look at this, or maybe slightly. The other thing, we don't know the condition of this patient. Remember, I mentioned some patients, they are unable to do the standard things, but this patient was in supine, as you can see, not in the left lateral decubitus. Thank you for that clarification. I was aware of this position. Thank you. It's okay. That is it. Apical 4 chamber. Okay. We can also have apical 3 chamber view with the patient still in the left lateral decubitus. These are modifications. They just the way you twist your probe, you can pick them. You pick like, so when you hear of apical 4 chamber, that should be your key. Understand it, how to pick the apical chamber, stress to know it. These modifications, apical 2 chamber, apical 5 chamber, they are just views that you can modify to visualize other structures properly. For example, this is the left atrium, okay? Anterior mitral valve leaflet, posterior mitral valve leaflet. Blood will move from there, it goes this side, and then it will come and join the left ventricle outflow tract until it goes to the ascending aorta. So there are times you can't appreciate nicely in the apical. Open it. Look at this. Okay, I cannot see the aortic root here. But this same view, I can modify this to have this. I can have this one practically, how you orient your probe. So your key have a 4 chamber view. Nicely, well done. This is practical. And then appreciate that. But the objective of this is to show you that don't be surprised if you see this image. This is a 3 chamber view. Which chambers are they counting as 3? 1, the left atrium, 2, the left ventricle, and the outflow tract is also considered as part of the chamber. It's a passage from the left ventricle to this. So 1, 2, 3. Though it looks part of the left ventricle, it's also considered the 3 chambers. Subcostal view. Remember, I talked about this. The patient can remain in supine. Flex the knees. The reason to flex the knees so that you can relax the abdominal muscles so that the patient is not tense. Put your probe, pick your subcostal. Best view for pericardial effusion. And also to quantify certain congenital defects. Okay, this is very important view. This is how it looks, subcostal view. The left ventricle will be there, right ventricle, tricuspid, RA, intra-arterial septum, and the left atrium. It's also a 4 chamber view. 1, 2, 3, 4. Very important. This is the pericardium. We explained why it's looking like that. It has bright echoes, it's a fibrous tissue. I wanted to also show that modalities can be explained, can be applied on different images. The modalities that we know is the pulsed wave, continuous wave, color Doppler, and which other one? Tissue Doppler imaging. Just to make you get oriented on what are these things. For this one, this is the pulsed wave. This is a pulsed wave. They were picking at the mitral valve level. This is pulsed wave. This is tissue Doppler imaging, TDI. They were measuring the mitral annulus, the medial annulus, the lateral annulus. Don't worry, I'll explain this when we come to do the actual stuff. I'll explain this. But this is when you see these images, tissue Doppler imaging. Okay. Tissue Doppler imaging just deals with speed, the velocities of the myocardium. And remember, I said it measures low velocities less than 20 millimeters per second. Put that in your mind. It may come in your test. And then you also have we are still doing tissue Doppler. Also, this is tissue Doppler. So this is how you can apply them. I'm just showing you. Suprasternal view, patient position. I explained that this is very important to assess the aortic arc. You want to see what is happening with the branches of the aortic arc, the branchiocephalic, the left common carotid artery, the left subclavian artery. You pick them from there. This view is very important when you want to check for coarctation, aortic aneurysm, and basically to see what's going on with if there are any congenital anomalies there. Aortic dissection, this is what you do. Patient position in total supine, extend the neck. Okay, I think I said I'll show you why a cavalier may not be the best. Okay, so if you see this, the patient can extend the neck and then you put your probe there. Orient yourself to what anatomy are you seeing. If you don't know the actual anatomy that you are seeing, you'll just be measuring things anyhow. So this is how you put your marker points to the head, and then this other one points to the left. You're going to have that structure that you expect. How does it look? It looks this. This is how it looks. So this is now the aortic root. Imagine from the left ventricular outflow tract. It's coming now out, ascending aorta. Once it caves like this, it gives these branches. The first branch is the brachiocephalic. Actually, the brachiocephalic is here. The second one is here, and the third is here. There are 3 branches that comes out. It comes nicely. This is a normal one. And then it becomes a descending aorta. Okay, it comes like that, and then it comes like that. This is the right pulmonary artery. This is the left atrium. So when you do your suprasternal view, this is what you get. This is what you get. Nicely. Okay, when you apply your color here, I just wanted to show you that this is the arc. Okay, and this is how it comes. I will explain why it's looking red here. I think I have a slide on why. The idea is to get you oriented to these images, why they appear the way they appear. Okay, suprasternal view. Okay, I also wanted just to show. Okay, left common carotid artery, this one comes out there. Okay, it goes there. And then this one is the left subclavian artery, and then the descending aorta we explained here. This is just color, nothing much. Okay, color Doppler application. You need a color Doppler machine, so use it. So how do I see color Doppler? Here I want now to explain why colors appear the way they appear on echo. Judith, are you there?
Yes.
Okay, tell me, there was an abbreviation that was written BART, B-A-R-T. What does it mean?
B-A-R-T.
Yes.
I don't know.
Thank you. Victoria, B-A-R-T.
Blue away, red towards.
Thank you. Thank you. Blue away, red towards. So this is where the scale comes in. Okay. When you look at this scale, this is the color code scale. This line that you are seeing here, there is a line that separates between the red and the blue. You see it, it's called the baseline. The red going up it tells you the positive Doppler shift. Positive Doppler shift going towards the probe. Red going towards the probe. Blue going away from the probe. But that blue away, red towards applies here. Now, this can be inverted on certain machines. Don't always think it should be blue and red, you cram that. It can, this is traditionally we use this, but it can be inverted. Remember, red and blue has got nothing to do with either deoxygenated blood or oxygenated blood. So you have to take note of that. I'm trying to explain this. Now, how do I explain now the color Doppler on parasternal long axis? Here, just concentrate on color. I want to emphasize the point on color. My point is to emphasize on color. So, here now I want you guys to be with me. Twambo, are you there? Twambo, are you there? Okay. Twambo, are you there? Mwinji, are you there?
I'm around.
Okay, tell me, what structure is this? I just want a structure based on what we've discussed.
That's the left atrium.
Thank you. This is the left atrium. Thank you so much. Judith, are you there? Judith. Okay, Victoria.
It's the left ventricular outflow.
Tract. Yes,
Tract.
left ventricular outflow tract. Yes, there's a reason why I'm asking this. Who else can I pick? Okay, I want people to participate. Rachel, what structure is this where I'm pointing? What territory is this? What territory?
The left ventricle.
It's a left ventricle. Thank you. Now, I want to explain why we are having these different colors. I want to explain why we are. Are you able to get me? Hello?
Yes, we are getting you.
Okay, thank you. So now blood is coming from here, the left atrium. It's filling here. Now, as it goes towards this side, the probe is here. Remember, it's at 90 degrees here. Okay, we are now learning about a bit of physics. The probe is here, the beam is here. So anything that is going towards the probe, it will appear red somewhere here, because physiologically, blood is moving from here, going this side. It's going from this side physiologically. In the back of our mind, we know that blood is moving from here, coming this side. So it will appear red as it comes here. As if that is not enough, it goes into the left ventricle, and physiologically, again, it has to continue going to the left ventricular outflow tract. But as it reaches here, remember, this outflow tract has to blood has to be pumped out of the left ventricle to start going this side now, to come out of the heart. So it's now going away in relation to that. It's now going away. So it will appear blue. So blood in the left ventricular outflow tract, it looks blue because physiologically it's going away. Don't be surprised here if you find a mosaic color, mixed color here, because there is turbulence. There is turbulence here. Blood, the other blood is trying to come here, the other one is going this side. Physiologically, you can find mosaic color here. Mosaic color, it looks blue, it looks also red. So there is this. So red coming here, it comes here, and as it comes here again, it changes the color. Any questions here on these colors before we move?
We move. Hello,
For me, yes,
hello.
we can move.
We move.
Yes.
Yes, yes, you can move.
Okay, thank you. Again, I'm now applying color in the apical four chamber. What I'm trying to assess here is just to you to understand that physiologically, you have to understand how blood is moving physiologically. Here, I deliberately picked this one to demonstrate regurgitation. Don't worry about regurgitation and everything. But remember, blood moves from the left ventricle, the blood moves from the left atrium going to the left ventricle. Now, when the mitral valve is closed, it simply means the left ventricle or the cardiac is in systole. It's contracting. There you should agree with me. When the mitral valve is closed, because it's closed, we can see here, it's closed. Then the left ventricle is in systole, it's contracting. So when it contracts, this mitral valve must be tight. It should be tight. But we are having this backflow of blood coming this side and it's appearing blue. It's not appearing white. This is how regurgitation appears on echo. Regurgitation is when blood is going back from the left atrium. Physiologically, blood must not go back to the left atrium. So it's appearing blue. So just this is enough for me to say this is a regurgitation. Regurgitation, it's a systolic diagnosis. You see it in systole. Why am I talking about in systole? Because the heart has contracted. We expect all the blood to be pumped out of the left ventricle via the left ventricular outflow tract through the aorta. But we are having some blood that is leaking here. Why is it leaking? Because the pressure here is very high, about 120 millimercuries. It's very high here. So if this valve is not tight, it will leak. How is it going to leak? It will give you a blue sign, which is a negative Doppler shift. Okay, this is the three chamber view, which I explained, but I also want just to show color. This is the right atrium again. Okay, blood is moving. Here it's nice now, red. You can see nicely red. It reaches there, left ventricle. Physiologically, blood must start coming. It changes to blue. The same blood. This is a negative Doppler shift. The same blood. The direction of blood is changing. So know your physiology. And this is in diastole. In systole, blood is moving like this. Next. Color Doppler on aortic arc. We know this. We know this. Now, look at this. This is AAO. This is ascending aorta. Ascending aorta. This is the same ascending aorta. So ascending aorta is coming from the heart. So why is it red? Because it's coming towards, the probe is here. It's coming towards. The moment it reaches a certain level, it starts going away. The blood changes to blue. The flow changes to blue. Because of this, just here, it's coming towards red. Once it goes away, pulsed wave. I want you to understand this pulsed wave. I think it was one of the assignment, but pulsed wave in the area explanation we mentioned, or I mentioned that the pulsed wave, this measures normal velocities across the valve. You measure normal velocities. So it's one of the important modalities that we use in echo, particularly to quantify diastolic function. I won't explain all the details here, but I want to show where you put the sample gate. This is very self-explanatory. You don't put your sample gate there. You don't put it there. You put it there right at the tips of the mitral valves using the apical
4-chamber view. Put your sample gate at the tips of the mitral valves, not below. Why are you putting on the tips? Because this is where you're having the maximum flow, the maximum inflow of blood passing there. And when you talk about Doppler, you and me by now, we know Doppler is all about blood velocities. It's not an animal that we should start thinking, hey, what is Doppler? When you hear of Doppler, think of blood velocity. We want to quantify blood velocities. So once you put your sample gate there, this is what you pick. Okay. Now, when you pick that, what is this E and what is this A? What is this E and what is this A? Now, before I go further, when you look at this line here, that line is called the baseline. What is the baseline? The baseline, this is just the division of the negative shift Doppler shift and the positive shift Doppler. From here, going up, you can see this is in milliseconds. This is velocity. This is just speed. This is just speed. It's positive. From here, going down, this is the negative shift. It should be in negatives. So the flow going this side and the flow coming this side, it's the same, except that this is a positive shift going towards the probe, and this got down, it's a negative shift. This is how you explain this. This is the time again, velocity, speed against the time interval. The x-axis, it's a time interval, and this is the speed interval. That's why when you do this, you are even able to pick the fetal heart rate here. You can even pick the heart rate here because this is the cardiac cycle. Now, what is the E? E, you have to understand where it's coming from. I'll go back to the phases, the diastolic phases. These diastolic phases must also be understood. And you can only understand these diastolic phases when you know where they are coming from. And as long as you don't understand these diastolic phases, you keep making mistakes. So the E, it's from the 4 diastolic phases, the early phase. Remember, I said there are 4. The isovolumetric phase, the rapid filling, which is also called the E, the isovolumetric, and last, the atrial kick or the atrial contraction. We don't see the whole 4 phases. We only see on echo 2, the early phase or rapid filling, and the rapid filling, and the atrial kick. So the E, you pick it when blood has rapidly filled the left ventricle. I'll explain this during diastolic dysfunction, but I want you to see that the E is picked when there is early filling or rapid filling of the left ventricle. When it's filling, the blood will pour. A lot of blood will pour into the left ventricle and give you this E. Now, some blood will remain in the left atrium. The left atrium will contract and squeeze the remaining blood into the left ventricle. It's called the atrial kick, which is labeled as the A, the E and the A. This is the normal wave. The normal wave when the heart is filling, you've got the taller E and the shorter E. Where are these things coming from? Why is this taller? This is shorter. It's because during rapid filling, there is high velocity of blood going to the left ventricle, and there is atrial kick, small velocity, and that cycle continues. We explain this, and this is what they are trying to explain here. On echo results or echo report, you find people have put the EA ratio. EA ratio. It's the E wave and the A wave. The EA ratio should be more than 1. We'll explain these things when it comes to the actual stuff. But I wanted to show you the pulsed wave on the mitral valve, and this is how it comes out. Don't get surprised or you find this wave. Remember, it also looks like the M, okay? Like the one we had on the M mode on the mitral valve. It looks like the M. So it should not confuse us. This is still a tip that I just wanted to show. The pulsed wave with the correct positioning towards the probe, upward signal, it's giving you that, and the A. The baseline, this is the baseline, okay? We'll explain it. Pulsed wave Doppler setting for mitral valve. We'll explain them very well. What is the key point on this one? Know the correct position for sampling, understand the physiology on what's going on, understand each and every part. This is the baseline, okay? The baseline simply divides the negative shift, the positive shift, and the negative shift, okay? Pulsed wave on apical 4 chamber, I was also just trying to and demonstrate. This is the positive shift, and here, this is now the baseline, showing you the negative shift down here. This is very important when we come to talk about regurgitation and everything. We'll explain them. This is continuous wave. Last time I mentioned about continuous wave, it measures high velocities, and we use it to quantify abnormalities like regurgitation in shunts and defects. Here, they were trying to quantify regurgitation of the mitral valve. Blood regurgitating to the left atrium, you use continuous wave. We don't use the pulsed wave to quantify regurgitation or shunts, or trying to know exactly what is the abnormality of that particular blood flow. We use continuous wave. Okay, this is now the flow of blood on the aortic valve. I want to still explain why this is like this. When blood is moving from the left atrium, it comes to the left ventricle. It has to go out through the left ventricle outflow tract via the aortic route. It comes this side. It's not going towards the probe. It's going away from the probe. So if the aortic flow is coming away from the probe, and in color we saw it as blue, it simply means it's a negative shift. It won't go up there. It will be below the baseline. But we know that it's the same blood flow, but it's a negative shift, and it gives you this typical sign. This is the normal flow of the aortic valve, commonly referred to as the dagger sign. Dagger as a knife, dagger sign. Okay, this is the common, it's a negative flow. So when you see this flow, somebody has done an echo, you see this flow. Don't worry, don't get confused. Is it a negative flow? Is it a positive flow? Why am I saying this is a negative flow? Because I know the physiology of blood flow within the heart. I understand it. And I know exactly what I'm trying to quantify here. It's a normal flow I'm getting. Okay, normal flow of the aortic valve still. So the moment I'm going to have another flow here, behind here, I'll show you how to quantify aortic regurgitation, because aortic regurgitation, it's a positive flow. It will be going towards, it will go towards the left ventricle. So when the aorta is regurgitating, it goes into the left ventricle, and going to the left ventricle simply shows positive regurgitation. Okay. Okay, I wanted to show you the normal tricuspid flow. This is how it flows. When you see this, by the way, echo images, they look so funny, but we pick a lot of information, and you can only pick information when you know. The eye sees what it knows. It cannot start talking about things it doesn't know. Okay, post wave on the pulmonic valve. I was also trying to show you the pulmonic valve. Now, the pulmonic valve, again, when you look at it, it's a negative shift. Why is it a negative shift? Because of its physiology. So for blood to go through the pulmonic valve, it has to come from the left ventricle, from the right ventricle. Right ventricle right ventricular outflow tract, and it goes away from the probe. That's why it's like this. This is a baseline. This is a baseline. So no confusion should come. Okay, related anatomy to the aortic pulmonic valve. I wanted to demonstrate this. This is the Benz sign. I talked about the Benz sign. RVOT, right ventricular outflow tract. The leaflets are here. The main pulmonic artery, and then it comes like this. Imagine the probe is here. So blood will move and comes like this. So pulmonic regurgitation, it's a positive shift. I hope it's making sense when I say positive shift and the negative shift. Normal flow of the pulmonic valve is a negative shift. Okay, this was the aortic arc. This is aortic arc. Okay, so when you look at this, we know how the aorta is moving. We know how the aorta is, the aortic arc is moving. We know how the aortic arc is moving. So blood is moving from the aortic root coming down this side. So normal aortic arc flow is a negative shift. That's why it's below the baseline. This is my baseline. By the way, the baseline can be adjusted either up or down. Mr. Moab, I think we talked about aliasing. Okay, so aliasing, sorry, when you look at this, this is about 80 centimeters per second. This is the velocity. So when you're having the speed of blood is somewhere here, it's somewhere down here, it means the flow is so much. But remember, pulsed wave cannot peak high velocities. So it will have a wrap up on top there. That is called aliasing. There will be another image that will come like a line. It's an artifact. So what you need to do to accommodate the high velocities, you adjust this up. Check on your machines. There's somewhere where it's written baseline. When you just turn it, this scale will go either go up or it will go down. Sorry. It will either go up and go down. When you just adjust, it will go up or down. So when you push it up, if the velocities are still high, you still won't manage to reach that Nyquist limit. So that becomes an issue. So you adjust. When you can't still pick the highest velocities, switch on to a continuous wave. Now you are dealing with either regurgitation or stenosis and all those things. But this is a normal flow of the aortic arc. It's a negative flow. So this was a long lecture. What is the take-home message? This is the end. The take-home message is that I wanted you guys to be familiar. I know this is a lot of information. Be familiar with the echo structures, understand the physiology, get to understand why things are done the way they are done, and more importantly, understand that you need to know your anatomy and physiology with a well-detailed physiology and what really happens with the heart. So I know this will provoke you now to read, and I think I've also demonstrated why I'm emphasizing on people to understand what they are doing. So at this juncture, I'll allow any contributions, questions, and clarifications, and where you didn't understand, I can repeat. Thank you so much for your attention. You can please go ahead with if there are any questions.
And for me, I would just like to give a contribution, like just to talk about what I've gotten.
Sorry,
So,
sorry, just
so much
just
information.
speak up. Just speak out. I can't.
I said it's just more of a comment on today's lecture.
Okay.
Yes, it was a bit bulky, which was okay. Though it was a lot of information, but it's very fine because I understood most of it. And the thing that I appreciated the most was on color Doppler.
Okay.
color Doppler is oxygenated and the oxygenated blood. So now I've understood it better and it makes more sense. And I've really appreciated that part a lot.
Thank you.
I
Thank you
now
so
know
much.
that it's all in relation to the probe. Yeah.
Thank you. Thank you. No, we thank you for that comment. Thank you. If things are making sense, then we are safe. Please, any comments? Any comments?
Mr. Mulenga.
Yes, sir.
I think it's like a practical situation in training, like what the previous speaker said. I have widely understood now Doppler and how important it is to know your anatomy. So if let's say I put at a gate, okay, mitral valve, what structures am I seeing, especially
Yes.
in M mode? So I've seen
Yes.
the value of the M mode. Why is it important for you to understand certain
Yes.
structures? I think that cannot be overemphasized. So
Yes.
basically, I think there's a lot to take home and be able to grasp it. Where we are not clear, I think I'm sure the door is always open.
Yes, yes,
Thank
yes,
you so much.
yes. No, thank you for the comment, Mr.
assimilate
Mama.
certain things.
Thank you. Any comments, contributions, clarification?
Mr. Mulenga.
Yes, yes, madam.
Yes, thank you for today's lecture class. Esh. There's a lot of information, but I noted some of the things. And I'm just asking if you can post the recording so that we go through.
Okay, okay.
Yes,
No, I
for
think
last
again
class.
for last. Okay, okay. No, I'll do that. I'll definitely do that.
Otherwise, thank you so much.
Okay, and maybe if there is so much, we can always break it into smaller parts. We are not rushing anywhere. You can always say, okay, give it in bits. But I'm looking at time also because we have stuff to do.
Exactly. Oh.
Yeah.
No, the best thing is also maybe after a class you post the lecture so that we go through and check in our test books so that we read further.
Okay. No, I'll do that today so that I bring them out. Any questions, comments? Yeah. Any comments?
My request was actually
I'm coming again.
Recording
you can go ahead, please.
Because I joined class late and somehow I misdirected myself. I was thinking it was starting at 19 hours. So my request was in line with the previous speaker who requested that you share.
Sorry, Mr. Mwamba, I can't get you, sir.
Me now?
Yes, I can get you now.
I was saying mine was a request just similar to the previous speaker for the recording to be shared because I joined class at 19 hours. I somehow misdirected myself thinking it was going to start at the same time. I did not check that much earlier. Thank you.
Okay, no, I would definitely do that immediately once I upload it. I noted some others, they came late. No, it is noted. Questions, comments?
Mr.
Any
Mulenga?
suggestion? Yes, sir.
I was thinking because the different levels of understanding.
Yes.
My idea was more like you give chance to us to assimilate this data. I don't know when the next lecture will be, so that even in the way we have the group, if someone has a question, maybe we have a time where we can ask questions where we are not clear, then you are available to answer those questions. Or each one, or any one of us who has understood, we have that forum of discussion in the WhatsApp group. Let's use the WhatsApp group as well, so that we, in relation to what Vicky was saying, it will help us to assimilate, to say, okay, today we are talking about this. And then in the group as well, we have that time to say, okay, specifically, just as we have the time specifically for the lectures, even for discussions where each one of us is present at least, okay? So that we are able to move at the same pace. I don't know if I've been understood.
Yeah, I think it's clear. I think just on the same, I would suggest that I know people have got a lot of groups, but what we've done with the specifically for official communication, and then we leave that group for any academic related, you just post academic things, nothing like no, me this, no, this, notice board and case discussion or anything. That's where those things can be. So like the way we've given this lecture, people can start putting questions, we discuss it on that, the one we have current, but I'm suggesting we have a notice board just for communication purposes only. Okay, and any questions? I think those will handle them. Any questions, contributions? Twambo, any comments? Rachel, any comments? Mwinji, Mutinta, anything?
I'm going to have another assignment today.
So I'm giving you another assignment today because their assignments are ready. So they will just be coming. And okay. I think I'm almost done marking the ones which came in. I'll give them to you tomorrow. Okay, at this juncture, I'll close the lecture unless there is anything to clarify. I'll clarify them from the group, and I think most of the people they have called concerning the assignments and everything. So these assignments will also be discussing them. We'll be having them like a discussion. We won't have a lecture, but we discuss the answers and the assignments. The idea is to digest this material so that when we speak, we know what we are talking about. But please do me a favor, just dive into anatomy. Just dive into your echo will frustrate you if you don't know your anatomy and physiology. That I can assure you, it will frustrate you. You will cram things. Please digest your anatomy bit by bit, bring it, we discuss it. Let's know what we can. We are all in the learning curve. So let's bring things out. Otherwise, thank you so much for your attention, and I think the request has been noted. We'll do everything possible so that we can perfect everything. Thank you so much, and have a, unless Mr. Mwabade is anything, or Mr. Msonda, anything that is burning that we can clarify. Otherwise, I'm done.
For me, nothing else, just to thank you for your commitment and time. Let's stick to the same program as we have agreed. And I urge each one of us to be free with each other. Yeah, we are all on the different level of learning. That's all I can say. Thank you so much for your time and everyone who took time to listen to this lecture. It has been very, very, very helpful. Thank you.
No, thank you. Thank you so much. We can end here and have a pleasant
good night.
Thank you so much.
Meet you the other side.
All right, no problem. All right. Okay, boss.